Today, I'd like to introduce Dr. Iris Brunner. She is an associate professor and researcher at the University of Aarhus in Denmark. Specifically, she works at the Hamel Neuro Center and is involved with clinical neurorehabilitation. She received her PhD from the University of Bergen in neurorehabilitation. She has authored academic research across a variety of topics related to neuroscience and rehab. I just gave a quick introduction there, but I was wondering if you could tell us a little bit more about your story. I'd love to hear about your background and, your journey to get to where you are today.
Of course. Thank you very much for having me, Robert. So I'm a physiotherapist by background, and I've been working with neurological patients almost all my professional life. I grew up in Germany and trained as a physio in Berlin and then moved to Norway some 25 years ago. And 7 years ago, I got this exciting job opportunity here in Denmark. And since then, I'm commuting between Norway and Denmark. So as you mentioned, I'm a researcher and I work at Hamel Neuro Center which is the largest neurorehabilitation institution in Denmark.
Yeah, it seems like it's been an interesting journey thus far. And I noticed you mentioned you're kind of commuting between two countries. Do you kind of live pretty close to the border?
No, it's not close. No, it's quite a long commute.
I guess to kind of go a little bit back in time to maybe the beginning of the journey, what sparked that initial interest in neurorehabilitation for you?
Yeah, well, it was the main reason to train as a physiotherapist because it was a nice combination between psychology and movement science. And I've always been interested in psychology, and this is intrinsically related to the brain and the function of the brain. And what sparked my interest was simply the complexity of neurological damage and accordingly the complexity of neurorehabilitation. When I worked as a physiotherapist, I could see what a brain damage could do to a person on all levels. I mean, how it can affect their physical function, their cognitive function, also their behavior, and even change their personality. And personally, when I was in Bergen, I took almost 20 years ago, I took a university course in psychology. And then for the first time, I was confronted with the scientific thinking and the world of science. And yeah, maybe it may sound a bit pathetic, but then really a door to a new world opened, and I tried to combine that with my professional background, and then went on to a master's degree and a PhD in neurorehabilitation.
It's really awesome that you were able to find this topic or this subject that combined a lot of your interests and a lot of the things that you wanted to pursue all together. Just to help set the stage or the context for the listeners of the episode, can you just give us a quick overview of what neurorehabilitation is, and how it's applied in stroke patients, and then also some of your experiences maybe applying the technological tools in this space?
Yes, of course. So neurorehabilitation is quite a broad field, which includes diagnoses such as stroke and multiple sclerosis, traumatic brain injuries, and other acquired brain injuries. So the most frequent, most common is stroke. And maybe I should say a few words about stroke, since the audience is not necessarily health professionals. A stroke is caused by a clot in an artery or a hemorrhage. And this results in a blockage of the area that it supplies, and it does not get the oxygen. The brain area does not get the oxygen that it needs, and nerve cells die. So according to the location or the damage, but also the networks that are affected, people with stroke suffer from motor and cognitive impairments. The motor symptoms are frequently a hemiparesis, that is control over one side of your body, or people not being able to walk or use their arm. And there can also be cognitive and psychosocial consequences, such as difficulties on concentrating, memory loss, and change behavior. So it's a life-changing event for many, and it is very frequent. I think in the US, it's almost 800,000 people who experience a stroke every year. And roughly a third of them is under 65. So it's it's the most frequent cause for lasting impairment, and many of the patients or the people that suffer from stroke will have to live with the consequences for a long time. And so it's very, very important the level of function that we can achieve during rehabilitation is very important for the next decade or more decades for the people affected. And according to the impairments, the rehabilitation is complex and has to address the challenges that the person experiences. And at the same time, it has to be intensive enough to induce changes on a neural level. And neurorehabilitation helps the brain to adapt and to compensate for damage. Yeah, this is basically where technology comes into the picture. So I always think that technology is not a treatment in itself. It's a means of delivering a treatment, a means of increasing intensity, of sustaining motivation for training. And in most cases, it just helps patients to engage with their rehabilitation, and it has many advantages, and it can provide us with a huge amount of data. So if you want, I can give some examples from the types of technology I worked with.
Yeah, I'd love to hear some examples.
Yeah, so it started with a VR rehabilitation system for upper limb training already in 2009 or so. And it was a system for stroke patients. And it was a system called the U-Grabber from a Swiss startup, a spin-off of the ATH in Zurich. And their patients could play games to improve their arm and hand function. And they wore gloves that registered their movements. And the games were either accelerometer based or camera based. And I think you wouldn't call that virtual reality nowadays, because it was not immersive. They didn't wear any headsets. They just interacted with the screens. So, and this was when we did research on that system. And in hindsight, I have to say that it already included many of the features that I still regard as quite essential for a useful rehabilitation training system. So the accelerometer-based games could capture really small movements, and many of our patients are not able to do larger movement, at least in the beginning, shortly after stroke. So the system could really catch minute movements and transfer those to a screen and make a person interact, for example, steering a plane or steering a car. Yeah, this was a very important experience for them, that they could do something with their otherwise rather useless hand. So that was really a fantastic tool. To be able to use that, and also to be able to receive the feedback from the system, the visual feedback, the auditory feedback, and also to be able to follow the progress. So that's one of the huge advantages of virtual reality training or augmented reality training, or in general technology, that we can support people who have very little function in the beginning. And at that time, we did a multi-center study with that system, which actually showed that the people with severe paresis, the people who hardly could move their hands and arm, actually did many more repetitions when they were training with the virtual reality system. Main result of the study that virtual reality training was not inferior to standard rehabilitation, but it was not superior either, I can say. So that was a very interesting experience. At the moment, we are working with another system with virtual reality, which we developed together with engineers and computer scientists from Aalborg University, which is for the training of spatial neglect and related disorders. And maybe I should say a few words about spatial neglect. So this is an impairment of attention, of perception of mostly the left side of the body, that occurs after a right hemispheric stroke. So it's It's quite frequent in the beginning of the stroke. Up to 30% of people are affected. And it can be quite bizarre in extreme cases. So people may sit on their hand without realizing it. They may shave only half of their face or eat only half of their plate, only the right side, and ignoring the left side. But there are also many milder cases which can be quite difficult to diagnose. And here virtual reality system really can be a huge help. So we have integrated eye tracking, and we can follow their head movements, we can follow their controller movements, and we can exactly see how people change over time.
Interesting that only one side of the body is affected, and I think you said it's generally the left side. Is it ever the reverse, where maybe there was some sort of stroke in the left side of the brain and the right side gets affected?
Yeah, the right side can also be affected, but normally these cases are not so severe.
Got it. Yeah, that makes sense.
So the really extreme cases are in people with right hemispheric damage, and then since most nerves cross to the other side, then it's the left side that is ignored.
Why is the use of technology so relevant in neurorehabilitation? I know you mentioned it kind of helps with the delivery of certain therapies, and it can also help like intensify certain treatments, for example. And then I think something that you also mentioned was that it kind of helps with collecting data, like things like eye tracking and such. And so I was just wondering if you could kind of delve into, what brings the relevance of technology to the forefront in the space of neurorehabilitation?
Of course, there are many good reasons to apply technology in rehabilitation, and I think it's one of them is that it helps to offer really personalized rehabilitation. We have this term precision medicine from cancer research, and this is applied also in other areas of medicine, but it can also be applied to rehabilitation, because exactly the data that is generated allows us for much more precise diagnostics and also for personalized rehabilitation. And of course, any therapist, any physician would claim that they offer personalized rehabilitation, and rightly so. However, it's the precision with which we can, for example, adapt motor training to exactly the level of difficulty that is appropriate for a person is quite unique. So if we assume that, say, an error rate of 20% in a game, say shooting molds would be okay to keep it challenging, then if we can integrate an algorithm that keeps constantly that level of difficulty, automatically adapts to either an improvement or of function or a decline of function, then this is just very much more precise than any therapist could do. And so patients can be kept exactly at this sweet spot where we think plasticity occurs, where we think skill learning occurs, and this is a huge advantage. So the point is to let patients make mistakes and to keep the training challenging, but not so many mistakes that people get frustrated. And that might also individually be quite different, how much frustration an individual tolerates or needs to continue. And as you said, the data that we get, they are seamless. So we get data from each session, and otherwise we have tests at different defined time points. But maybe the patient has a bad day and cannot perform at their best on a specific day, and through the monitoring during each session, we get a much more comprehensive picture. Maybe most important in general for the application of technology is that many of the principles that we regard as being essential for skill learning, for experience-dependent plasticity, and for motor relearning can be implemented in rehabilitation systems. So just as I mentioned, keeping the challenging character, but also many repetitions, the more motivational factor. It's a means of increasing intensity of rehabilitation. And it also enables patients to train on their own without a therapist present, so they can train after therapy hours, they can train during weekends, and also after discharge. And also there are really many good reasons. So it can be combined with telerehabilitation, which is extremely valuable in remote areas, or for people who are so frail that a journey to a rehabilitation service would be too exhausting. And yeah, and as I said, the playful character. So most people like to play. It's always amazing to see how engaged even elderly people who never did any computer games can become in a rehabilitation game. So that is very appealing. Though on the other hand, sometimes it's exaggerated what companies promise, how much fun their rehabilitation system will be, in contrary to the super boring physiotherapy or occupational therapy. If you have a choice of, say, 10 games and only 3 of them are suitable for your specific patient, also those will become quite boring after a while. And lastly, I think we will need technology to address future changes in neurorehabilitation. So we still get older, and there will be an increasing number of people in need for rehabilitation, also in developing countries due to lifestyle changes, diabetes, overweight. So there will be more strokes and an increased need for neurorehabilitation, and we will not be able to handle that without the help of technology.
It seems like there's a wide array of applications here for these various forms of technology within neurorehabilitation. And yeah, I can definitely see how it could be useful in a lot of these ways that you described. And thus far, we've been talking a lot about the usefulness and the positive aspects of technology, but I was wondering if you can expand a little bit on where are we at now with implementing these sorts of technologies, and are there any challenges standing between our current state and a future state of like routine clinical use of rehabilitation technologies?
Yes, I think we are on a very good way, but of course there are challenges. So it can be quite difficult for a hospital to decide on which technologies to invest. So the day you purchase them, they are outdated in a way, and there will be a better model soon. And as I said, technology is not a treatment in itself. You still have to know what you are doing, the rationale behind it. That's why we spend a lot of time with a system that we are currently developing in integrating therapeutic principles, and did not spend much time on fancy looks and nice graphics at the moment. So we need to know what we want to achieve, and technology has to be implemented. So it's not just enough to buy a system. You have also you need people around. You need people who can work with the system. At our hospital, we have special interest groups that are established around certain technologies. So there is an electrical stimulation group and a robot assisted training group, and these people are super users and can instruct others. They receive updates, and they communicate with the companies, and they receive further training. And yeah, this is one of the challenges, the reliable support from the company side, from the producer side. So this is essential, and there have been several startups who really designed and produced very nice products, very nice rehabilitation systems, but then they went bankrupt. And as soon as the first problems arose, people were left on their own and could not get any support any longer. So these are the challenges from a clinician perspective usually.
Definitely some challenges to overcome, and that leads me to ask a follow-up question. What exactly do we need, as an industry or as a hospital or as an academic center? What is needed to scale up the meaningful use of these types of technology in rehab or neuro-rehab settings?
Yeah, that's a discussion that we frequently have at conferences and research meetings. So, well, what we need and what we, of course, already practice is co-design, so that engineers, health professionals, and patients working closely together to develop user-friendly and relevant rehabilitation systems. So this is something that has become so much better during the last decade. So I remember when I started working with technology assisted rehabilitation, it was sometimes hard for the developers, the IT people, mainly healthy young people, to imagine how impaired a person can be. So the rehabilitation games they programmed, even the easiest level sometimes was way too difficult for a person with impairments. And on the other hand, the therapists had totally unrealistic expectations to what could be coded and programmed into the system. So I think since we are talking much more together and really co-developing more, that this has become much better. So co-design is crucial, and also collaboration and continuity. So to create evidence from multi-center studies, because this is another backdrop. Usually the evidence is lacking. So it takes an awful lot of time to do studies, and even more time so to do studies with a substantial number of participants. So that's why we need collaboration, because it's always a challenge to recruit enough patients, especially in rehabilitation studies. And we need the continuous development. There are many really fantastic PhD projects, postdoc projects, and good ideas, good systems, and they just die after the project period is over, because there is no further follow up. And this is why research and development should be sustained over an extended period of time, and we should be able to exchange ideas and data on a larger scale. So here in Europe, we have these cost action. That's an initiative of the European Union to support collaborations on science and technology. And we have now applied for one regarding spatial neglect and related disorders. And we have established a collaboration with people from more than 20 European countries, and also the US and Canada. So hopefully we will get funding. So large international multidisciplinary networks that work together and exchange ideas, technologies, and people would be great.
Yeah, I agree. That would be great. And those topics really resonate with me. I think, wide collaboration across countries or, across different regions is really useful, just to bring lots of ideas into the mix and lots of potential applications into the mix. And then the co-design point especially resonates with me. I've heard that from a lot of people, where the clinicians need to understand what's possible to build, and then the engineers need to understand what it is that the clinicians actually want or actually need, and what it is that would actually be helpful for the patients. And I think the deeper or wider these communication channels between these two groups can be, the better technologies and better therapies that will end up getting built. I'd like to pivot into a specific project or a specific technology that you were involved with. So the listeners of this podcast are super interested in brain-computer interfaces, and you've recently been involved with a couple projects focused on BCI for patients, as you mentioned, with severe upper limb paresis after stroke. And just wondering if you could share with us some details on what drew you to get involved with this research topic, what has been learned from a clinical perspective through these studies, and then also what specific aspects of BCI, stroke rehab, would you like to see more information or more research on in the future?
Yeah, BCI are very much debated at the moment. BCIs or brain-machine interfaces, BMIs, are indeed very interesting. So just transferring your thoughts into actions and movements, and transferring your thoughts into language is just fascinating. Well, we did this a small pilot study on BCI training with a system that is commercially available. And specifically, we tried it on patients with severe upper limb paresis. So that is people who basically cannot move their hand, who may have some arm movement, but they cannot move their hand. And we recently published a paper on this study. We could not find a significant effect in favor of BCI training in this study. However, we realized, and this is one of the lessons that we learned, that we may have included many patients with no potential for recovery. Because when we looked at the data from the examinations with a transcranial magnetic stimulation of these patients, so those patients who had some corticospinal tract preserved, they had much higher chances of regaining some upper limb function, totally independent of what kind of training they received. So it's, and maybe we could not provide enough intensity during the time that patients were admitted to our hospital, but I think it's, and that's a challenge in general with rehabilitation studies. That's not limited to any technology, or just showing an effect of intervention A compared to intervention B is a huge challenge, because you have so much spontaneous recovery ongoing in the first phase of the stroke, and also all other rehabilitation that people receive. It would be unethical to withdraw that. So that makes it really hard to show an effect of whatever. But I mean, in general, it's still, yeah, I'm still super interested in brain-computer interfaces, but maybe I see a bit larger potential in using them as assistive devices, and maybe to a minor extent as restorative devices. But there's still a lot of interesting research ongoing. But yeah, that would be great, because what we get with BCIs is this closed loop from motor intention, then the motor action, and then maybe you get the appropriate sensory feedback, the tactile and the proprioceptive feedback. So that's very close to a natural movement, and that makes it interesting. Patients were really amazed when they saw that they could lift their hand with the help of their thoughts. So they received electrical stimulation on their forearms, and when they were able to recruit the right networks in their brain, then the electrical stimulation was applied, and they could really see that something happened. And yeah, that's just great.
Yeah, absolutely. Very interesting work that your team was working on. Very interesting findings. And yeah, thanks for kind of giving us that overview and explaining the details of that project.
But I think when we are unfortunately we're not quite there with regard to brain computer interfaces. So they are still bulky. They still require a lot of training and a lot of dedication. So still a lot of work to do.
That makes sense. Yeah, lots of innovation needed in the space before they could become more widespread and applied to more applications. I would agree with that. In a lot of situations, they can be very bulky, and a lot of versions of them can be more invasive than people are looking for, or maybe not able, for the bulky ones, maybe not able to take home, for example. So lots of things to consider here.
Yes, indeed. And you would in the long run, you would want something that is less bulky, that is quite inobtrusive, and that does not require your full attention just to do a motor action. So there are still challenges ahead, and also who pays for it? I mean, who is entitled to receive that kind of device? Who pays for it? That's also challenging and different in every country.
Definitely complicated issues to work through, especially that payment aspect that you mentioned. It seems like each country's health system or insurance system or situation is much different, and it's a lot of work to kind of go country by country and get things like this approved by the regulators and then also set up for payments.
Yeah, and also the acceptance. So that is that these things should become a part of standard treatment. So although we use quite a broad array of all kinds of technologies, there's still a long way to go. So therapists have to be trained, and integration in treatment protocols, and as you said, who pays for it, and does it give so much extra benefit? Is it worth the money?
Something I'm looking forward to keeping an eye on and seeing what people decide about these things when they decide, is it worth the money? When they develop training programs, for example. We've kind of been talking a little bit about the future here. And so I was wondering, do you have any predictions for like applications of technology to clinical neurorehabilitation over the long term, maybe perhaps the next 20 or even 50 years?
That's quite a very long term. So how do they say predictions are difficult, especially about the future?
Yeah.
So I don't dare to make any long-term predictions, but I think for the next decade or so, I think that all kinds of rehab technologies will be much more common. And we will need to realize flexible solutions so that more people can be provided with rehabilitation at home. So this is, where I see the biggest problem for healthcare services in the future. Yeah, and as I said, I hope that they will be user-friendly, inobtrusive exoskeletons, robot gloves that will help those people, and there are quite many of them, unfortunately, who cannot recover their function, so that their natural function can be replaced in a way, and that they will be able to steer them with unobtrusive EEGs, maybe just an ear EEG that catch your intentions and translate those in a variety of specific movements, not only a few rather coarse movements, and without requiring too much conscious attention, so that you maybe will be able to continue conversation while you are grasping your cup of tea or whatever. So I don't dare to wish anything beyond the next 10 years. I think that's beyond my imagination, how the healthcare systems and societies in general will change.
Well, it definitely sounds like there's a bright future ahead, though, with lots of options for the patients, hopefully, and maybe innovations that may bring rehab opportunities into the hands of more people. And so I hope that that future that you envisioned there ends up coming true.
Yeah, me too.
My next question is for the listeners who may be looking to get involved in the neurorehabilitation space. Do you have any tips for them on, first off, how to get involved? Second off, what sorts of listeners might be interested in a space like this?
Well, you can get involved in many ways. I would say just do it. It's fascinating. Either if you are on the health professional side or more on the engineering side. So it's especially this interdisciplinarity and the close collaboration of different disciplines that makes it so interesting, both medical and non-medical, and it's very rewarding. And in a way, neurorehabilitation is applied neuroscience and much more, of course. And that's fascinating.
I totally agree. Before we signed off, I was just wondering, is there anything else we haven't discussed that you'd like to mention or bring up?
We covered quite a broad range. Maybe just one last thing, that we must really focus on the end users and what makes a difference for them. So how can we really improve their function with the help of technology, and how can technology contribute to a meaningful life when a real improvement of function cannot be achieved any longer?
Yeah, absolutely. It really is important to keep the end users at the very front of mind, and especially in these like translational situations, or when you're trying to translate technology and get it out into the field, you have to be thinking of the end user. I think it's better for everyone. It's better for the technologist, it's better for the end user, it's better for the clinicians.
Definitely, yes.
Should any of our listeners contact you for further discussion after the episode? And if so, how can they reach out to you? Who should reach out to you? And then also, what sorts of topics should you be reached out to about?
I'm always happy to discuss any technically assisted stroke rehab topics, and they could just drop me an email. So if you Google my name, you will find me, and I think that there are also all my email addresses. And if somebody is interested in collaborations for studies, please, just get in touch.